The following program was paid for by Atlantic Neurosurgical Specialists. The views and opinions expressed on Answers Live are not necessarily those of the staff and management of the station. Management has not investigated the claims made during this program. The views and medical recommendations of guests on Answers Live are not necessarily those of Atlantic Neurosurgical Specialists. As always, consult your health professional regarding any medical decisions.
Welcome to Answers Live, your community medical connection, making a partnership of good health. The studio lines are open for your calls and questions. Call 973-267-9687. Now, here's your host, Tom Wood.
Good morning and welcome to Answers Live, your community medical connection, creating a partnership of good health. I'm your host, Tom Wood from Atlantic Neurosurgical Specialists, also known as ANS. We are the largest subspecialized neurosurgical group in the state of New Jersey. Our main office is right here in Morristown, New Jersey at 310 Madison Avenue in Morristown. Our main number is 973-285-7800. To visit us on the web, it's ansdocs.com. Again, that's ansdocs.com. As I always tell all my listeners, visit the website to look at all the new and different changes happening here at ANS. We have a very robust website with a lot of educational materials there. You can also read about our centers. Our newest one is, as everyone knows, is our Brain Tumor Center with Dr. Yaron Moshel, who's part of the Glasser Center at Overlook Medical Center. So go on there and read that. Also, go to my website, which is answerslivenj.com. Again, that's answerslivenj.com. That's where all the shows that I do here on Answers Live will be always posted. You can listen to those shows as much as you want. You can download them. You can link them. And just like I said, if you need the information, it's there. As you know, we've been doing this for quite a long time, probably 3 years, and there's a lot of information. Again, I always scan the area for the top-notch specialists in the area. So again, today I'm going to be bringing to you Dr. Angela Alistar. She is the new medical director of Gastrointestinal Medical Oncology right here at Morristown Medical Center. In particular, her research focus has been related to the immuno-oncology and cancer metabolism in gastrointestinal cancers such as pancreatic tumors, colorectal, esophageal, gastric. So it's a large amount of different types of specialized cancers, like I said. So we do wanted to bring her on to speak to you, in particular today about that area. Good morning to you, Dr. Alistar.
Good morning, Tom, and thank you for having me.
Thank you so much for coming. This is a large, broad topic that we're going to touch base on today. Before we got on the air, we were talking about other topics that we're probably going to bring you back for. So I'll let our listeners know that we're probably going to be doing a show on cancer and nutrition. She has my ear and my interest already. So just to give all my listeners a teaser, we'll be bringing Dr. Alistar back in the coming weeks or months to do that show. But before we get started, Dr. Alistar, just let our listeners know a little bit about you, a little bit about your educational background, and what you're doing up at Morristown with this type of specialty.
Absolutely. So I'm a GI oncologist at Morristown Hospital. I have joined approximately 3 months ago a brand new hematology oncology division that is aiming to create a new model of providing excellent cancer care in the community. Our focus is to bring clinical research and clinical trials right here in Morristown to our patients in order to reduce the stress of traveling to New York or other major cities to just to be enrolled in a clinical trial or to have a second opinion. So we are hoping to create this hybrid model of academic medicine in a community setting. I have joined Morristown, as I said, approximately 3 months ago, coming from Wake Forest University in North Carolina, where I was a GI oncology leader for clinical research, and where I developed a full portfolio of GI of gastrointestinal clinical trials for the Comprehensive Cancer Center there. Okay. A GI oncologist, I should say a GI medical oncologist, is an expert in treating gastrointestinal cancers. And really, to simply understand this, gastrointestinal cancers are cancers that start from your esophagus or your mouth all the way to the anus. So it involves the the stomach, the small bowel, the large bowel, the pancreas, the bile duct, the liver, and my expertise and my focus for the last 7 years has been in gastrointestinal cancers. As we will be addressing a little later, I have had significant success in pancreatic cancer research, and we'll be talking about this exciting new possible treatment for patients with pancreatic cancer.
Okay, so at your office or your center, you bring together a bunch of different specialists with you. Again, like we've kind of formulated our group with Dr. Moschel at the Brain Tumor Center, where a few specialists come and meet the patient at one time. So you don't have to go to New York, you don't have to travel. All the latest trials are there. You meet all different types of specialists in one setting. Which is amazingly helpful to anyone who is recently diagnosed with this type of cancer. So that's what you're trying to do.
So that is an accurate description of what we're planning to do.
Okay.
We are going to have a multidisciplinary clinic.
Right.
So when a patient with, let's say, colon cancer comes and sees us, they will see the surgeon, the medical oncologist, the radiation oncologist, the nutritionist, the social worker, the palliative care
person, right? To
provider, or the whole team will be there to just address all the needs in one setting.
That's incredible.
And that is, I think, very important to reduce the stress level of our patients,
right,
as opposed to, waiting to see everybody until a final plan is formulated.
Right. And it's been very successful, like I said, in the brain tumor, with our group being involved in that. Because as my listeners know, once you get that diagnosis, your whole life changes. And to be running to 5 or 6 different specialists and trying to get them all to get the reports at the same time and talk. So this is really something that's really exciting that's happening right here in Morristown Medical Center. Let's get down to the kind of the basics to start really getting into the show. What are the most common types of GI cancers that most people get? And all my listeners, we're going to ask you this question and some of the obvious causes, if you can give them.
So the most common gastrointestinal cancer, I would say, is colon cancer.
Okay.
However, it seems that there is an increase in prevalence for pancreatic cancer, an alarming increase in prevalence, I should say. And pancreatic cancer is anticipated to become the second leading cause of death from cancer in the United States in the next decade.
Wow.
So I think that we cannot really relax despite of the new treatments that are coming on the pipeline. I feel that having wonderful treatment opportunities is as important as preventing these cancers.
Okay.
It's kind of hard to give you a very specific list of symptoms that would cover everything.
Right.
But I would say that in general, changes in appetite, changes in weight, changes in energy level. Sometimes depression is a symptom that is very common in gastrointestinal cancers, and it's hard to tease out whether it's depression or fatigue, or some patients just don't feel well and they think they're depressed when in fact their energy level is lower because of a cancer.
Right.
I would say any kind of changes in the bowel pattern that is not resolving by itself should be brought to the attention of the doctors. Obviously, the obvious ones like nausea, vomiting, bleeding, those are I think those are easy to address.
Okay.
In general.
So those are the big ones that we all, I'm still stuck on. You said pancreatic cancer, because when anyone hears about pancreatic cancer, you hear those people are diagnosed and they pass away so quickly. And usually it's the stars that we hear about, but that's a scary one that's actually on an upswing. Colon cancer, like I said, I believe we did a show maybe a year and a half ago. As I'm sitting here, my heart's racing because I have to go for my colonoscopy because I am over 50, and my wife's going to listen to the show, and so we do have to go, babe. We keep putting it off, and we do have to go. So we do have the doctor, and we're making the appointments next week. So, and I'm not just saying that, we really are. But all joking aside, that's something very important for people over the age of 50, if I've learned correctly, for colon, to have your first colonoscopy, correct?
That's correct. And a colonoscopy nowadays is very comfortable. The most annoying part of this test is actually the prep. But really, during the procedure, you're sleeping, you know nothing, and you feel nothing. So the test is really not a stressful test. It's just spend 1 day in the house cleaning your bowels. It's going to feel good anyway.
To get at all the impurities in your body. We went through that, my wife and I, so we're going to do it. And I'm not just joking, we are, because we have been putting it off because you think you're busy and we feel fine, but it's not something really because it is a very curable cancer from what I understand if you catch it early.
That's correct. Just like cervical cancer, if women wouldn't do pap smears, we would have a much higher rate of cervical cancer. So for colon cancer, a colonoscopy could be life-saving, and I would not delay by any more time. If you're 50, you should have had it.
Okay. Yes. So we're a little past that, but we won't go into that. I want to jump back a little bit more into the pancreatic, because again, that kind of just scared me the way you said that, because you hear these stories, people are diagnosed and they're dead within months. So I wanted to kind of go over a little bit about, you're saying right now, is it the third leading cause right now?
It's the third, and in the next decade is going to be the second leading cause of mortality from cancer in the United States.
Okay. I know you don't have this answer, or maybe you do, but why is that happening?
Well, we think that one of the reasons is obesity, and the fact that in general, our patients do have a higher weight. It's not the only reason, but obesity is now considered to be a risk factor for all cancers.
Okay.
And for pancreatic cancer is obviously in the same category. We don't have the other reason pancreatic cancer has such poor statistics is because it doesn't have a screening test like colon cancer has, and it doesn't have any kind of screening blood work that you could possibly do. So and then to make it even more complicated, the presenting symptoms are very vague. As I said, could be just low energy, just not feeling well. Well, maybe I'm depressed. Maybe I didn't sleep enough. Maybe I'm not eating well. Maybe I have a stressful job, and it takes few months before something feels really wrong for patients to go to see their doctor. And it's striking to me to see how many patients think they have depression when in fact they have low energy. That is due to pancreatic cancer. The other item to sort of look for is a development of diabetes in an older patient without no good reason.
Okay.
That could also be a warning sign of pancreatic cancer to come.
Okay.
As you know, pancreatic cancer develops in the pancreas that has two functions. One is the endocrine function, and one is the exocrine function. The endocrine function is related to insulin, which keeps our metabolism going. The exocrine function is related to the enzymes that our pancreas has to make to help us digest food. So pancreatic cancer can come in two different flavors. However, the most common one is the adenocarcinoma that comes from the endocrine cells.
Okay.
From the exocrine cells, yeah.
I was just going to ask you that. We're going to take a quick break. I want to get a little bit more into this pancreatic cancer. We'll be right back.
There's a unique place in New Jersey that more and more people are discovering. A pioneer in healthcare leading the way with programs like their nationally recognized spine center, skull-based surgery center, and their brain tumor center. That place is Atlantic Neurosurgical Specialists, ANS, improving lives with exceptional neurosurgical services, medical firsts, and one-of-a-kind programs. ANS, home to New Jersey's largest group of world-renowned fellowship-trained neurosurgeons offering advanced treatment options. ANS, a leader in stroke care with a success rate greater than the national average. Among the first in the country to use stent retrievers, allowing surgeons to immediately restore blood flow to the brain. ANS, the leaders in spine care, using the latest minimally invasive techniques for spine surgery that actually reduce recovery time from weeks to days. ANS, restoring hope and helping patients regain their lifestyles. And it's all happening right here in New Jersey. For more information, go to ansdocs.com or call 973-285-7800.
Welcome back to Answers Live. I'm your host, Tom Wood, and I'm here with Dr. Angela Alistar, who is the new medical director of Gastrointestinal Medical Oncology right here at Morristown Medical Center. When we left the show, we were for our break, we were talking a little bit about different types of cancers. We left off real quick with pancreatic cancer. You were telling us about the kind of the two sides of the pancreas. A question that I get a lot, just being in the medical field, is why is pancreatic so deadly? Like, you could live without a lot of your organs, of course, for the obvious ones, but why can't you remove a pancreas and give medicine to give your enzymes and your insulin?
Right. So I think that is an excellent question. The pancreas is a very sensitive organ that really is in charge of keeping the whole machinery going because of the insulin. So yes, we could possibly, we can take out the pancreas, let's say for a patient who has an earlier stage pancreatic cancer, and then use insulin for that function. However, we will never get as close to perfection as our body was to begin with. And then the whole digestive tract is really a very sensitive system that is dependent of healthy organs. So every time you interrupt this normal, cyclical, very sensitively coordinated system, you will have all kinds of things to adjust to make it work again. So that is one of the reasons the pancreas is such an important organ. The other reason pancreatic cancer has such a terrible reputation is because this is one of the cancers with very high symptom burden. So patients do feel a lot worse in general, statistically, than patients with other tumor types, which places them at disadvantage up front when you think about chemotherapies or other kind of therapies that they may need.
Right.
Because it's harder to tolerate chemotherapy if you're already not feeling well. So our advancements in pancreatic cancer research have been slower than for other tumor types because the patient population is a lot more vulnerable. Right. That is one of the reasons. Secondly, pancreatic cancer, in my opinion, is a very intelligent cancer that has developed all kinds of mechanisms to resist every single intervention we have tried in general. So far, really only chemotherapy has been able to make progress in pancreatic cancer, and that's not from a lack of trying. Extensive research has been performed in pancreatic cancer, and it's still lagging behind in comparison with other tumor types.
So that's why mortality is so prevalent with this type, and the life expectancy is shorter?
Yes.
Because usually you hear someone has pancreatic cancer and then months, and they're just not there. So it's scary. That's
right.
At least,
so it's diagnosed later. It's most of the time is diagnosed at a later stage, which means a worse prognosis, which
Correct.
means more symptoms, which means that the patients already have a lower ability to tolerate any kind of treatments because they haven't been eating well for 2 months now, and they are not as fit for treatments as they need to be. So for that reason, I think awareness about pancreatic cancer is vital in order to lead to diagnosing it sooner. Okay,
makes a lot of sense. My other question for you is: do genetics play a role in the pancreatic cancer and other GI cancers?
So this is a about 2-day conversation, but I will try to summarize it in few phrases.
Minutes.
Yeah. So I think that we're learning a lot in this era of precision oncology. We're learning a tremendous amount about mutations and what kind of drivers every tumor may have. And we now realize that every patient with another tumor type is very different than the next one. Even if you match them by age and demographics and other medical problems, every single patient is a different kind of disease, has a different kind of disease. So yes, I think genetics have a lot to say, and explain why there is such variability in outcome. And this is why I encourage my patients all the time not to look at their neighbor who had pancreatic cancer and had whatever kind of experience, because every patient is different. Every cancer has a different profile of mutations that determines the outcome, their tolerance to treatment, their sensitivity to
certain drugs. Right.
To certain drugs. So I believe that in the next 5 to 10 years, we're not going to call it pancreatic cancer, colon cancer anymore. We're going to call it X mutation cancer or Y mutation cancer.
Right. On that note, where you're saying every cancer is different, every cell makeup is different, what is the immune oncology and cancer metabolism? Because I know with the brain tumor, that's kind of a specialty that I have because I work for that group. They kind of take that tumor and treat that tumor, not that person. It's that tumor, what it's made up of, and so on and so forth with the trials. Is that kind of what's going on in your neck of the woods, so to speak?
So immunotherapy is about the most exciting development in gastrointestinal cancers in the last few weeks. And immunotherapy is already known, I think, in the community for other cancers. And I was waiting to see the progress in gastrointestinal cancers as well. Immunotherapy is not chemotherapy, is not radiation, is just another class of medicine that enables your body or the patient's body to fight cancer back. There are all kinds of different immunotherapy drugs, and just recently, we had the most spectacular approval of an immunotherapy for gastrointestinal cancers, irrespective of where the cancer originated in the gastrointestinal tract. So this is, I think, a first in for the FDA to approve an agnostic location for a treatment. We traditionally have had a gastric cancer trial that was randomized, and this drug is better than the other one. And now we have a class of drugs, immunotherapy, that is approved for a certain subpopulation of patients with MSI high, which is just a molecular definition of some.
The makeup of it?
Yeah, of patients with gastrointestinal cancer. So irrespective where it originated, if you have an MSI high tumor, you are a candidate for immunotherapy. And the results so far are spectacular. It's not always curative, but it's one of the most exciting, I think, therapies that have happened in gastrointestinal cancer in the last few years.
Okay. We're coming close to the end of the show, but I just wanted to ask you overall, because I know my listeners, they talk to me a lot. Out of all the GI cancers, is colon the one that we're most concerned with as far as prevalency and occurrence, and something that could be prevented easily by having your screenings?
I think that colon is probably the low-hanging fruit here, meaning that screening colonoscopies will most likely help patients either be diagnosed at an earlier stage where it's still curable, or just be diagnosed with colon cancer before the symptoms happen.
And how about, like I said, we'll just kind of go down the line with your mouth and your throat. We had one of your colleagues from Morristown, Dr. Thomas, came out and talked about throat cancer. So mouth, throat, esophagus, the prevalency of those that you see. Where do they rank in all this for the people getting cancer? It seemed like with the HPV virus, with Dr. Thomas, that throat cancer in men over 50 seemed to be on the increase also. Stomach cancer, I hear a lot of people with stomach cancer also. What is the prevalency of that in general?
So I would say that colon cancer is probably the most common in the community.
Okay.
And all the other GI cancers are more risk factor related. For example, liver cancer are related to hepatitis, are related to alcohol, and again to obesity.
Right.
It's really hard to necessarily classify it from a screening standpoint.
So the one that's easier is the colon because it's a screening. And I'm trying to get my listeners to understand that something as simple as I'm sitting here not having my colonoscopy yet, but I'm going, you should be getting those things done first. Like I said, pancreatic, there is no test. There's no nothing. You got to pay attention to your body. Eventually, we'll get you back and talk about nutrition and doing a healthy living. Obesity is huge. So my listeners know we've done many shows on obesity and weight loss. Those are things that we could take care of. But the immunotherapy sounds very exciting. Is that started already at Morristown? Have you started that?
So it is. I have been using it even before it was approved.
Okay.
However, it had an accelerated approval, and now it is something that we can use for a subset of patients. It doesn't cure everybody. It's not for everybody, but if you have any kind of gastrointestinal cancer, you want to make sure that you are or you're not a candidate for immunotherapy. And it is now part of every conversation I have with a patient in my clinic. The other really important point I would like to stress is that clinical trials are the only way to make progress in cancer. And in my opinion, every patient with gastrointestinal cancers should be enrolled in some sort of clinical trial. We have many questions we have not answered. If it's not a treatment question, it could be a quality of life question. It could be a supportive care question. It could be a prevention hypothesis that we have to prove. So I would very much encourage our patients to help us unlock this code that is cancer. I'm specifically focused in gastrointestinal cancers. I will be bringing to Morristown a very interesting new treatment in pancreatic cancer and other tumor types. It's called CPI 613, and this is an anti-metabolite. It targets the metabolism in pancreatic cancer, and it has been shown in a phase 1 study that I designed and conducted at Wake Forest University to have very dramatic results for patients with stage 4 pancreatic cancer, and now is going into a international phase 2 to 3 study looking at the combination of standard chemotherapy with this new agent that's called CPI 613. So maybe at another date we can talk about metabolism and cancer.
Absolutely.
And that I think would tie very nicely into nutrition and what we can do to improve our chances to survive.
Fight this, right. Yeah, well, we could definitely do series, and my listeners know we kind of get on a topic and then we get into it. We kind of do a series with you, so if you're more than happy to do that with you. Our show is coming to a close, but before that happens, I do want to know how someone make appointment with you. Let me give the phone number for Dr. Alistar. It's 973-971. I have one number as 7111, and then there's another one here, which is 973-971-7960. They're located right here at 100 Madison Avenue at the Carol G. Simon Cancer Center on the 2nd floor. That's right here in Morristown. Always go on the website, which is atlantichealth.org/GI cancer. Dr. Alistar, before we leave, I always ask my guests to give a takeaway message. So sum it up as best you can for our listeners on this topic.
You want a takeaway regarding cancer in general? What can you do to just?
Yeah.
I think the best we can do is we should use our common sense when it comes to cancer. We should have a very low threshold to call our doctor if something doesn't feel right. You shouldn't wait 2 months for a symptom that's not resolving. Call your primary care doctor, your gastroenterologist, whoever is easier to find. And get a medical opinion. As you, and I'm so proud of you that you're going to do your colonoscopy. I have had mine done, by the way. You should always stay on track the best you can with your
screenings
and your preventative medicine. nutrition is key as well as exercise, and it has proven to increase survival irrespective of what cancer you have and what treatments you have.
Perfect. Thank you so much, Dr. Alistar, for coming on the show, and I'll talk to all my listeners next Sunday. Have a great day.
Thank you.
Join us again next week for Answers Live, your community medical connection, making a partnership of good health.
The preceding program was paid for by Atlantic Neurosurgical Specialists. The views and opinions expressed on Answers Live are not necessarily those of the staff and management of the station. Management has not investigated the claims made during this program. The views and medical recommendations of guests on Answers Live are not necessarily those of Atlantic Neurosurgical Specialists. As always, consult your health professional regarding any medical decisions.